Breathing is brought about by the action of the respiratory muscles, which produce rhythmic changes in the volume of the thoracic chamber containing the lungs. The rib cage and diaphragm form the walls of the thoracic chamber. Normally, there is no attachment between the lung surface and the thorax. They are separated by a thin film of fluid forming the intrapleural space. This film acts as a lubricant between the pleural surfaces. The lungs are held against the chest wall by atmospheric pressure. This pressure is applied at the surface of the body. Since virtually the same pressure exists within the lungs, it acts as a clamp or vise holding the lungs against the chest wall. The force of atmospheric pressure is opposed by the smaller elastic forces exerted by the lungs and thorax. When the respiratory muscles are relaxed, the elastic recoil of the lungs is balanced by the tendency of the thorax to expand. As a result of these two opposing forces, the pressure in the intrapleural space is less than atmospheric. This can be seen when the pressure is measured with a manometer. At the end of expiration during quiet breathing, this pressure is about 6 centimeters of water below atmospheric. The opposing elastic forces exerted by the lungs and thorax can be represented by the action of two springs. The coil spring on the left behaves like the lungs, while the flat spring on the right behaves like the thorax. If the connection between the springs is broken, they both recoil. Similarly, if holes are made in the chest wall, the lungs collapse and the ribs and diaphragm spring out. The diaphragm is the most mobile part of the thoracic wall. The position of the relaxed diaphragm is determined by the elastic recoil of the lungs and the opposing forces acting on the diaphragm. In the upright posture, the weight of the abdominal contents pulls down on the diaphragm, increasing the equilibrium volume of the lungs and thorax. To produce changes from the equilibrium position, work must be done. In breathing, this work is done by the respiratory muscles. The most important muscle of respiration is the diaphragm. We can show its action by means of X-rays. Here we see the movement of the diaphragm during quiet breathing. When the diaphragm contracts, it moves downward, and during expiration, it is pulled upward by the lungs' elastic recoil. With a deep inspiration, the maximum descent of the diaphragm is shown. Its mid-portion is pulled down like a piston. At the same time, its insertions pull up on the rib cage. The intercostal muscles assist inspiration, but their primary function is to stabilize the rib cage. Elevation of the rib cage also increases the volume of the thoracic chamber. During maximum inspiration, the accessory muscles assist the diaphragm and intercostal muscles. The action of the accessory muscles of inspiration may be shown on the skeleton. The shoulder girdle, neck, and head form a scaffolding. From this scaffolding, the muscles extend to the ribs and sternum. In contracting, they elevate and expand the rib cage. The scaffolding of the shoulder girdle and neck must in turn be supported by other muscles of the neck and back. With a deep inspiration, the back is extended and the shoulder girdle is raised. During rapid deep breathing, the shoulder girdle is raised and lowered, thus assisting the accessory muscles. This patient with poliomyelitis is entirely dependent on her accessory muscles. Note how she extends her neck with each inspiratory effort. This action aids the anterior neck muscles in pulling up on the sternum. Forced expiration is brought about by the expiratory muscles. The change in volume is produced by contraction of the abdominal muscles and by flexion of the back. The action of the abdominal muscles is shown here. As they contract, intra-abdominal pressure is raised. The diaphragm is forced upward, and the volume of the thorax is reduced. With a recording spirometer, we may now study the volume changes produced by the respiratory muscles. Inspiration is upward. The volume changes produced during quiet breathing may be compared with those produced during a maximum inspiration, followed by a maximum expiration. Note that after these large changes, the volume returns to the previous level. This illustrates the importance of the equilibrium volume of the lungs as a reference point. The equilibrium volume, represented by the dotted line, is determined by the elastic balance between the lungs, tending to reduce the volume, and the opposing tendency of the thorax. In quiet breathing, inspiration begins from the equilibrium volume. Inspiration is the active phase and is shown in red. Expiration is largely passive, and elastic forces return the lungs and thorax toward the equilibrium position. The volume change with each breath is called the tidal volume. The largest volume which can be breathed in from the resting position is the inspiratory capacity. Its limit is set by the strength and range of action of the inspiratory muscles and also by the elastic properties of the lungs and chest. The largest volume which can be breathed out from the resting level is the expiratory reserve volume. It is limited by the range of motion of the diaphragm and the fact that the rib cage greatly resists further decrease in volume. The largest volume that the subject can breathe out after a maximum inspiration is called the vital capacity. It is limited primarily by the strength of the respiratory muscles and the elasticity of the lungs and thorax. This patient has pulmonary fibrosis. His vital capacity is impaired because of decreased compliance of his lungs. This patient with poliomyelitis has a reduced vital capacity because of muscular weakness. The equilibrium volume indicated by the dotted line is not constant. For example, it is influenced by posture. In the upright posture, part of the expansion of the thoracic chamber results from the weight of the abdominal viscera pulling down on the diaphragm. When the subject is supine, the weight forces the diaphragm upward. This movement decreases the volume of the lungs and shifts the equilibrium in the expiratory direction. The vital capacity is about the same as in the upright position. The elastic properties of the thorax prevent complete emptying of the lungs during a forced expiration. The volume remaining after a maximum expiration is called the residual volume. It changes little with posture. The volume of gas contained by the lungs at the equilibrium position is called the functional residual capacity. The arrows indicate its change with posture. The fact that the lungs remain partly inflated at all times is important mechanically because of the influence of surface tension on lung expansion. The effects of surface tension may be demonstrated on cat lungs, which have been specially prepared and made completely gas-free. Lowering the pressure around the lungs produces no effect until a critical pressure is reached. The lungs begin to expand unevenly, as shown by the lighter areas. This irregular opening is due to the influence of surface tension within the small air passages in the lungs. With high magnification, the air sacs are seen to pop open individually. As the pressure difference increases, nearly all of the units open. Deflation, in contrast to inflation, takes place much more uniformly, and the small units of the lung remain open until the pressure difference is nearly zero. The relationship between pressure and volume can be shown graphically. There is no appreciable volume change until the opening pressure is reached, in this case at about 10 centimeters of water. A different curve is obtained during deflation. If each tidal volume began from the completely collapsed state, breathing would take place along the lower curve, and large pressure changes would be necessary to overcome surface tension. Furthermore, the tidal volume would be very unevenly distributed. In life, however, breathing takes place along the upper curve because the lungs are never allowed to collapse. The same tidal volume can be produced by much smaller pressure changes, and the tidal volume is more uniformly distributed within the lungs. At birth, the infant's lungs are completely collapsed. With his first breath, he must overcome surface tension to expand his lungs. During chest surgery, the anesthesiologist also works against surface tension to expand a collapsed lung. Whenever atelectasis occurs, forces of surface tension must be overcome to re-expand the lung. During volume tests, such as the vital capacity, the respiratory muscles work chiefly against elastic forces of the lungs and chest. During breathing, however, the muscles must supply additional energy to overcome frictional resistance to flow of air and movement of tissue. In exercise, the work required to overcome frictional resistance becomes increasingly important as the rates of airflow increase. In quiet breathing, almost all of the muscular work is done during inspiration, for the elastic recoil of the lungs and the chest during expiration is sufficient to overcome air and tissue resistance. The total oxygen consumption at rest is about 300 milliliters per minute. Only about 1% of this oxygen consumption is required by the respiratory muscles. With exercise, pulmonary ventilation must increase to provide for the increased metabolic demands. This is accomplished by increasing the number of breaths per minute, but more important, the depth of each breath. The increased depth of breathing means that more work must be done against elastic forces. The extra energy stored during inspiration is sufficient to produce the increased expiratory flow that is required. Expiration is still largely passive. At this level of work, the total oxygen consumption has been increased 5 times. Nevertheless, the oxygen consumption of the respiratory muscles amounts to only 5% of the total. In severe exercise, the energy necessary to overcome frictional resistance rises to high levels, and the expiratory muscles become active. During severe exercise, when the total oxygen consumption is 10 times the resting level, as much as 20% of the total oxygen supply may be required for the respiratory muscles alone. The tidal volume during heavy exercise is about half the vital capacity. The subject could voluntarily increase his tidal volume and breathing rate above these levels. But to increase his ventilation further would serve no useful purpose. The white area represents the oxygen consumption of the respiratory muscles. With increased ventilation at this work level, all of the extra oxygen taken in would be used by the respiratory muscles themselves. Thus, in normal subjects at high work levels, the work of breathing becomes a limiting factor. In asthma, the work of breathing, even at rest, may be greatly increased as a result of increased airflow resistance due to bronchoconstriction. This patient has pulmonary emphysema, a chronic disease often occurring as a sequel to asthma or chronic lung infection. In this disease, bronchoconstriction is frequently an important cause of respiratory disability, but additional mechanical changes of the lungs and thorax are present. First, the normal balance between the opposing elasticity of the lungs and thorax is upset. As a result of this disease, the elastic recoil of the lungs is diminished. The equilibrium volume of the lungs and thorax is increased. His chest is overexpanded even during quiet breathing. His inspiratory reserve is limited. In addition, his air passages are narrowed, and he has an increased resistance to airflow. Note how rapidly the normal subject can breathe out into the spirometer. Here the patient attempts the same procedure. The pressure applied to the lungs by his expiratory muscles is high, but the flow rate is low. During forced expiration, his lung resistance becomes extremely high. As a result of the increased resistance, greater pressures are needed to produce flow. During expiration, the pressure in the lungs surrounding the air passages is greater than the pressure within them, and they are compressed. This compression increases as the driving pressure rises. A vicious circle of events occurs. The harder the patient tries to breathe out, the higher the resistance opposing his efforts. The mechanism of expiratory obstruction can be demonstrated with a simple model. Here is a bottle with an attached syringe which is used as a pump to displace air in and out of the top of the bottle. An airway consisting of two pieces of glass tubing connected by a thin-walled rubber tube is placed in the bottle. The rubber tubing simulates a collapsible portion of the bronchial tree. In this instance, the lower tube offers little resistance to flow. Air can be moved in and out through the airway without much change in pressure in the bottle. As a result, there is little change in the diameter of the rubber tubing. This is comparable to the normal state. Increased resistance in the small bronchioles may be simulated by inserting a narrowed tube at the bottom. Much higher pressures are necessary to produce flow through the narrow glass tube. These pressures collapse the airway during expiration, increasing the resistance further. During a forced expiration, some of the airways in the patient's lung are completely shut off. The air beyond these parts is trapped within the lungs. The patient with emphysema cannot breathe out rapidly or deeply. Trapping of air within his lungs in large part accounts for the increased residual volume commonly observed in this condition and indicated here by the shaded area. Another disturbance of the patient's breathing mechanism occurs because the changes in his lungs are not uniform. For example, the air passages are not uniformly narrowed. This unequal change in resistance may lead to poor distribution of the inspired air within the lungs. We can illustrate this point with another model. Here, two elastic bellows are connected through equal resistance to a common channel. The syringe is used as a pump, and the volume change is shared equally by the two bellows. This is true when the changes are produced rapidly or when they are produced slowly. Here, the tube leading to the bellows on the right is much narrower. During very slow volume changes, the volume is distributed almost equally to the two bellows. As the frequency is increased, however, the bellows on the right receive less and less of the total volume exchange. As a result of localized differences in the mechanical properties of the patient's lungs, different parts of his lungs do not share equally in ventilation. This uneven distribution of ventilation is accentuated as he breathes more rapidly. Alteration in the mechanics of breathing may occur because of changes in airflow resistance, in lung and chest elasticity, and in the muscles which produce breathing movements. In asthma, the changes are chiefly in airflow resistance. In pulmonary fibrosis, they are chiefly in lung compliance. In poliomyelitis, they are related to muscular weakness. In emphysema, complex changes occur in all these properties of the lungs and thorax. Thus, an understanding of abnormal and normal lung function requires a knowledge of the mechanics of breathing.